like to introduce our speaker today, Dr. Stephanie Battistini. Dr. Battistini earned her bachelor's degree from the University of Central Florida and a medical degree from Florida State University College of Medicine. She then completed her pediatric residency at the University of Florida in Pensacola and then a chief viewer following graduation. She then came to Louisville and completed a developmental behavior pediatrics fellowship at the University of Louisville associated with Norton Children's. And she has continued to practice developmental behavior pediatrics in Louisville at our Norton Children's Developmental Center. She holds many hats in the Division of Developmental Behavior Pediatrics. She is a co-chief of the division, rotational director for residents from multiple subspecialties, and associate program director for the fellowship program. And welcome, Dr. Battistini. I'm going to turn it over to you, and she's going to talk to us about diagnosis and management of ADHD.
All right. Thank you, Dr. McDonald. I appreciate the introduction. Good afternoon, everyone. I hope y'all are enjoying lunch. ADHD is something I'm sure we all cover in each and every one of our clinics. And to be honest, ADHD probably deserves a whole symposium to really get into the nitty-gritty of everything. So I will do my best to cover some of the major highlights about ADHD today. So we're going to focus on several aspects of ADHD. I will hopefully go over briefly the pathophysiology of ADHD, then really hit home the DSM-5 criteria for ADHD. But what I really hope that you get out of this presentation is how to build your own toolkit in better serving our kiddos with ADHD. In Kentucky, Kentucky has one of the highest rates of ADHD in comparison to other states in the nation. So it is definitely something that we all see in our clinics on a daily basis. So I really want to help you guys kind of build your toolbox in the sense of assessment materials, medication management, as well as therapeutic options or therapy options that are available for ADHD. And I just want to highlight some disclosures. So I obviously have no financial disclosures, but I will be focusing this presentation on kiddos greater than 6 years old. The reason being is because those younger than 6 tend to fall into a category of complex ADHD, which deserves its own presentation on its own, which in December, just FYI, we will be holding a neurodevelopmental symposium and we'll cover complex ADHD at that point. But for this presentation, we'll focus on 6 years and up. ADHD medication management is an art. So I will be presenting recommendations that are evidence-based, but it is up to you as the provider to build your own toolkit as far as what you are comfortable with doing or not doing and learning when and when not to refer. And it goes without saying, but what works with one child with ADHD may not work with the next, and hence the art of it. So to start off, what really causes ADHD? And the honest answer is that it ends up being multifactorial. We do know that there is a level of dysregulation in two neurochemicals, norepinephrine and dopamine. And kiddos with ADHD just are not able to keep enough nori or dopamine out in the synapse for them to be able to organize their brain to focus, to help with that hyperactivity and then the impulse control. We are also aware that children with ADHD, that different areas of the brain appear to be working differently. And so, for example, the parts of the brain responsible for planning or self-control, which is typically right here in the frontal part of the brain, are typically less active in kiddos with ADHD. Then the parts of the brain that are managing more like in idle or when we're not really using our brain power to the max, basically daydreaming, they tend to stay there longer than anticipated. So hence the inattention or the inability to focus on task also become more apparent. And then the brain's reward system also looks to be developed differently in kiddos with ADHD, which is why kids with ADHD tend to do better with immediate rewards versus a delayed kind of reward system. And so kiddos with ADHD also tend to struggle with waiting. Research has also shown that the outer layer of the brain, aka the cortex, typically develops later than expected in ADHD children. So it's not that it's a permanent deficit, it takes sometimes that cortex peaks to develop, which then goes to say, which is why some children with ADHD as a kid may not have as profound of symptoms when they're an adult, because that cortex eventually does develop. We also know that there's an aspect of genetics here. Family history is very important with ADHD, and it is one of those disorders that it is inheritable. So meaning if a parent has like true ADHD, a confirmed diagnosis or true diagnosis of ADHD, there's a really good possibility that that child will also end up with ADHD. We also know that exposures, especially in utero, can definitely also influence or place a child at higher risk of ADHD. And so the diagram on your right just kind of depicts what I just described. And really, overall, ADHD, similarly to autism, it has a spectrum when it comes to it being presented in a patient. So with that, that is then leads us to the DSM-5 criteria, which is our diagnostic kind of Bible, if you will. With there are some things that I want to point out that are really important to consider when we are considering a child for the ADHD diagnosis. First of all, how long have the symptoms been present? And this is important because we know that children, especially in these earlier school years, respond differently to a lot of different things. So if there was a recent traumatic event, that kid may have inattention, may have some hyperactivity, may even be a little bit more irritable, therefore have some impulse control issues. But that is likely a response to the traumatic event that just happened versus true ADHD. So really ensuring that symptoms have been present for more than 6 months is part of the diagnostic workup, as well as symptoms being present in greater than 2 settings. This is important because children with a true disorder cannot hide their difficulties in one environment and then act out in another. So if at home there are concerns for ADHD, but school reports no concerns, I would first be looking at the environment to see what can be changed. And that could be simple things such as parent training therapy or other things. This is why it's important that symptoms are seen across multiple settings. Um, Obviously, symptoms also have to have a negative impact academically, socially. Self-care skills should be also impacted. In patients less than 17, you need at least 6 symptoms to make the diagnosis. And so the symptoms are split into inattention and then hyperactivity slash impulsivity. And the DSM-5 criteria makes it very clear as to what those symptoms are, and they're listed on the slide for you. And these can be reported, and we'll go over in feedback forms and letters from a teacher in your own clinic, and I'll discuss that in a minute. In addition, symptoms need to be present prior to the age of 12 years old. So a teenager who has done well academically, who then presents with concerns for inattention, I would do a much more thorough workup to see if there's some of the mimickers of ADHD that are actually being more present than ADHD itself. Symptoms cannot be better explained by other psychiatric disorders. There's a lot of psychiatric disorders that can mimic ADHD, anxiety, depression being some of the more common ones. So always keeping that in the back of your mind. And symptoms not exclusively a manifestation of oppositional behavior. So meaning it's not solely defiant behaviors. There are three different types of ADHD. We no longer use the term ADD. It is now under the term ADHD. And then you just specify the type of ADHD. So ADHD combined type means that basically all three core symptoms are present, and those three core symptoms are inattention, hyperactivity, and impulsivity. Or it can be in ADHD inattentive type, which means inattention is the core symptom. Or it can be predominantly hyperactive and impulsive type, which just as the name suggests, hyperactivity and impulsivity are the prominent symptoms. You can classify symptoms as mild, moderate, or severe. That has some room for interpretation, to be honest, so we mainly focus on the type. So the ADHD evaluation in the primary care setting can look differently depending on how your clinic is specifically set up. So if you're a clinic that is only given 15 to 20 minutes to evaluate, this evaluation may need to occur over several appointments. Whereas if you are given 30 to 45 minutes, this sort of evaluation may be able to occur in one visit. Your evaluation in the primary care setting should include a thorough past medical history, you're looking for risk factors, so birth history, prematurity, in utero drug exposure, as well as behavior and developmental history. And this includes, is the child in school? Are there any school concerns behaviorally? And is the child developmentally appropriate for their age? You want to also be able to obtain some baseline vital signs, and those include weight, blood pressure, and heart rate. Because if you do start a medication, those are things that need to be monitored as you manage medicines in these kids. I think something that is often not available readily for primary care providers are school records. And school records are something that can provide a lot of insight as to what's happening in that secondary setting. Parents can request copies of a child's full school record at any point in time. The school cannot deny parents access to the child's records, and they can bring those records to you. Specifically, you can ask parents to bring in a copy of the IEP, which is the Individualized Education Program, if the child has one. Maybe the child already has a 504 plan, which lists accommodations to allow them to be more successful in school. You could also ask if a child has an IEP. That typically means, there should have been, I should say, a psychoeducational assessment on that child. And that assessment should cover things such as cognitive testing, academic achievement testing, and self-care skills testing. Sometimes, depending on the school district, though, they may even include ADHD feedback form results on there, and that can be served as your feedback from a secondary setting to determine if they meet ADHD criteria or not. If you don't have access to school records or you're unable to get the information that you need from them, you can also obtain feedback from at least two settings via validated measure. And I think the most common validated measure that we're all familiar with is the Vanderbilt. Vanderbilts come in multiple languages. It is also free to use. And they have a parent report form and a teacher form. They also include like follow-up forms as well. And then in your evaluation, you should always consider if this could be something else, like one of the mimickers of ADHD. So like I said, anxiety, depression. But learning disabilities can also mimic a lot of ADHD symptoms, especially inattention. If a child is not understanding what is being told to them due to a learning disability or an intellectual disability, they're more likely to not focus on that subject because they don't understand. So just keeping that aware. So school records, when reviewing the IEP, you want to look at the primary disability. And this is typically for Kentucky. It is located on the first page in the very top, and it's labeled primary disability. The reason why you want to take a look, that is the educational diagnosis that the school system has used to build that IEP for that child. You can then review certain parts of the IEP. What you're looking for is for documented behavioral observations that have occurred as part of the IEP development team. So there's one of the first areas on that IEP is the present level of academic achievement and functional performance. There are typically paragraphs in there where the teacher will submit behavioral observations in the classroom. So that's one way to, again, obtain feedback from a secondary setting. You could also go to the section called Accommodations for Administration of State Assessments and Assessments in the Classroom. Again, there they would list things that they are helping the student with, so that way they can attend to class better. So for example, a common accommodation is being allowed a fidget toy at the desk, for example. You can also review the 504 plan. The 504 plans only list accommodations. Typically, for a child to meet criteria for a 504 plan, they need a medical diagnosis that is considered a disability in order to qualify for accommodations. And some kids may have the educational diagnosis of other health impairment, which is the school way of saying potentially ADHD. And then if you are able to access the psychoeducational assessment report, you want to take note of any IQ testing, adaptive testing, as well as behavioral reports. So let's touch on Vanderbilts for a little bit. So these are meant for ages 6 to 12 years old. They are used to assess for ADHD, but can also screen for ODD, conduct and anxiety and depression. The caregiver should complete the parent form, and then the teacher form can be completed by anyone from a secondary setting. So this could be the teacher themselves, the teacher aide, a therapist, counselor. If they are homeschooled, which I get this question a lot, the teacher can be like, if they attend a co-op group and there's another mom there who's also directing the activity for the day, they can obtain feedback from that individual. Or if they attend church school on a Sunday, they can obtain feedback from that setting, and that would count. You can also consider if the secondary setting is not comfortable providing like responses to the Vanderbilt, you can request that they write a letter about behaviors that are positive and negative for the child. I think one of the things that is often can be overlooked is really highlighting a child's strength despite their difficulties. And we want to make sure that the child is aware that, yes, we acknowledge that you have challenging areas in either attention, hyperactivity, or impulsivity, but they also do have strengths. So making sure that others are able to comment on their strengths is also important. So I just wanted to bring up an example of a Vanderbilt. So hopefully y'all have seen a version of this. Like I said, it does come in multiple languages. I have specifically chose questions 1 through 18 because these are the questions focused on ADHD, whereas the questions following 18 and more, those tend to be the ODD, conduct, and anxiety questions. How you score these is that you are counting the number of questions that either got a 2 or a 3 as a response. So you're not adding the numbers, you're counting how many of the questions received a 2 or a 3 as a response. If 6 or more, so it's split into 2 sections, so it's like 1 through 9 and then 10 through 18. If 1 or more of those sections have 6 or more symptoms, then there's a concern for ADHD in that current environment. So you would have to obtain a parent form as well as a teacher form to really cover the diagnostic criteria for ADHD if you're using the Vanderbilts. In older children specifically, you should also consider screening for co-occurring conditions. So these are anxiety, depression, learning disabilities, intellectual disabilities, delays. I placed on the slide some of the common screening tools used for those co-occurring conditions, but there are plenty of options out there to also consider. So the big question is management of ADHD, and this is where I get a lot of times questions from primary care about best next step or how do we start and those sort of things. So I have split the management presentation into first stimulants and non-stimulants, and then eventually we'll hit on therapy options because there are families out there that would like to avoid medicines for as long as possible, and there are therapy options out there if families are really persistent in avoiding medicines that they can get involved with. So with stimulants, what stimulants help with, it allows for more dopamine and norepinephrine to be available in the synapse. What this allows for the child is, since there's more dopamine and norepinephrine, they can then have better attention, better impulse control, as well as activity level may decrease as well. Remains the first line treatment for ADHD. Preferably, though, all studies show that stimulants plus therapy is always the best combo. But we know that therapy can be difficult to find. But so if you had to choose between a stimulant and a non-stimulant in a 6-year-old, the recommendation is to advocate for starting with a stimulant. All stimulants are pretty much approved for 6 and up. Disagreement between larger organizations remain as to whether to start with a methylphenidate or amphetamine. If you were to ask me, I have a bias towards starting with methylphenidate, and that's based on anecdotal experiences, not because I have some secret algorithm that has told me to start with a methylphenidate. If you ask some of my colleagues, they may report amphetamines. So really, there's not a good evidence-based algorithm to tell us what to start with, at how much to start with, and then what to do next. And again, this is where the art of ADHD medication management comes into play. The great thing about stimulants, though, is that the effects can be seen rather quickly. Stimulants work in that they're in and out in the same day. It is not a type of medicine that needs to quote unquote build in the system, such as like an SSRI, like Zoloft, or which is sertraline, or Prozac, which is fluoxetine. Stimulants really you can see the effects rather quickly. And family history matters when trying to determine where to start with a stimulant. Research has shown that if a parent has ADHD, what has worked for them will likely work for the child as well. So if you have access to the biological parents who have ADHD, and even if they're not currently treating their ADHD, asking them if they remember what medicine worked as a child is a good point to start. And that's typically what I will do with my patients, as typically one of the parents typically have ADHD. Now, if they don't recall, that's okay. But it does help quite tremendously when parents are like, oh yeah, I remember being on Ritalin and it worked fabulously with me and I didn't really have any side effects. Then we're going to start with Ritalin on the child, and then kind of going from there. Like with anything, you should always start at lowest dose and then titrate up at the family's level. So for some of my families, they want a longer they want gaps in between increases in doses. But for most of the stimulants, it's quite safe to go up on dosing within 5 to 7 days. Again, and it's just due to the mechanism of action of the stimulants. Now, when we switch over and look at non-stimulants, though, that is an area that's a big difference with non-stimulants. Non-stimulants should be titrated up as well as weaned off due to the fact that they require time for the onset to appear. So there are two major categories for non-stimulants. You have the selective norepinephrine reuptake inhibitors, and then you have your alpha-2 agonist. The SNRIs, which you will likely be familiar with, are atomoxetine, aka Strattera, and then viloxazine, aka Qelbree, or Quellbree. I honestly don't know which one is the right pronunciation. Um, and then for alpha-2 agonists, you have guanfacine and you have clonidine. Now, the recommendations really focus on the extended release, and the extended release are only FDA approved for 6 to 17 years old in the US, whereas the SNRIs are approved for 6 and up. The SNRIs are believed to really help address all three core areas of ADHD. Whereas, and that is because being an SNRI means that you inhibit the synapse from uptaking nori, allowing more nori to be available in the synapse. So it can help some of the neurochemical dysregulation that is occurring. Whereas the alpha-2 agonist is actually an old blood pressure medicine that when it was originally studied for high blood pressure was seen to make some difference in individuals with ADHD. And how this works, I kind of explain it to parents as more as a sedative slash chill pill because it just relaxes you, right? It's decreasing your blood pressure. So it really does better honing in on the hyperactivity and impulsivity portions of ADHD. It may, if you get a kiddo to sit longer, attend, kind of not move, then obviously their attention will increase due to that nature. But since it's not directly affecting the neurochemicals in the brain, it may not have a strong influence on attention. Non-stimulants are considered second line to stimulants, and they're typically used as adjuncts, meaning typically you have a stimulant already started and you're trying to figure out how to optimize your stimulant that you have on board. And one option is to add a non-stimulant on. And like I said earlier, non-stimulants do require titration and weaning. So something to be aware of. Now, medicines don't, they all come with potential side effects, and it's important to note what those side effects could be. For stimulants, the most common side effects you guys are probably already familiar with is appetite suppression. But it can influence blood pressure and heart rate, which is why you want to get baseline vitals before you start any medicine. It can change mood. Now, I will say the mood changes are commonly seen in more of those less than 6, not so much as those in greater than 6 years old. But I would say if you start a stimulant and an 8-year-old becomes, I will say, like a little Hulk, meaning they have very strong feelings. Um, they may not have ADHD. You may have just uncovered that they have a condition, a psychiatric disorder that mimics ADHD. When kids have true ADHD, they should respond to the stimulant as expected because we're helping with the norepinephrine and the dopamine that is dysregulated in true ADHD. When a child does not respond to ADHD as expected, we have to ask ourselves if it's something else that looks like ADHD. Research continues to show the better controlled the ADHD, the better the sleep. So stimulants, they don't really affect sleep directly, but since you have better regulation of the norepinephrine and dopamine, sleep tendencies tend to follow. Now, if a patient receives a stimulant too late in the day, that's where you can get sleep disruption, meaning it can affect the child and the child may not want to go to sleep on time. Stimulants can unmask tics. So stimulants do not cause tics, though. The child always had an increased risk of having tics, and then you give them a stimulant and just lowers the threshold for the tic to appear. SNRIs, the biggest complaint, well, I should say I see different side effects depending on which SNRI. So for atomoxetine, the most common side effect that I tell my patients about is the GI distress. It can also increase the blood pressure. Whereas the Qelbree, the biggest side effect or the most common side effect that is reported is more sedation, as well as suicidal ideation. There are some new studies coming out telling us that Qelbree may actually also help with serotonin levels. So there's some recent studies out saying that Qelbree might be a good option for those kiddos that ADHD plus or minus anxiety, because it does apparently do something with the serotonin levels, but that's not 100% clear yet. Um, and finally, the alpha agonists, so your guanfacine and clonidines, the big side effects there are obviously hypotension because it decreases blood pressure, and then sedation. But to be honest, a lot of us use guanfacine and clonidine for that side effect. So we may actually dose it at night to help with sleep onset, so the child can be more restful when they wake up in the morning. Now, I want to make you all aware of a great resource about all the different types of ADHD medications. This is developed by Northwell Cohen's Children's Medical Center. It is free to use, free to download. But essentially, I want to say every 2 or 3 years, it gets updated. This most recent updated was May of this year with all potential ADHD medications. It's a 2-page document, but I just took a screenshot of the first page, which really focuses on the methylphenidates, both long-acting and short-acting. Um, but some of the things that I want to point out, and I took just like a closer view of the form, is that so they go through and they give you the brand name of the different types of methylphenidates. It also lists what age it's FDA approved for. And then it also in this list will also go over how it's released in the body. And that's where different formulations can make a difference. So for example, focal and extended release, it says right here, it's biphasic, meaning 50% of it is released at first in one peak, and then the other 50 is released. Then if you see here, Contempla has a 25-75 split. Or it can be a continuous release, which is Quillavant. And it's important to note these differentiations because this may be a clue as to how a child is reacting or not reacting to a medicine. Every child will respond to these differently. So for me to put out here into the universe, step 1, step 2, step 3 will not make sense because unfortunately every child will be a little bit different. The other thing that I like about this chart is that the doses for each medicine, like all the doses in this first column, are equivalent to each other. So let's say you are considered 36 milligrams and you are considering trialing a different formulation of methylphenidate. You do not have to start from scratch and go to Quillavant 10 milligrams, for example. You could just start at 20 milligrams of Quillavant. So these doses across the formulations are supposedly equivalent. And then the other thing that I love about this chart, there's an administration key, and I took a zoomed in kind of picture of it, which tells you if these can be open, can they be chewed, can they be mixed, can they be done anything with? Because to be honest, for kiddos who cannot swallow pills, liquid formulations are far and few in between when it comes to ADHD medications. So knowing that you can open certain ones and sprinkle them on applesauce and things like that can really help a family out. I will often whip out this chart with the parents and visually show them all the options. And then especially for my families just wanting liquid, show them that I'm not making it up, that there's a very limited option for liquid and that we may have to help the child learn how to swallow pills. Or learn how to accept the capsules being open and then sprinkled on applesauce. And so on the bottom of both of these slides, I kind of put the web link for the PDF if you're interested in having this available in your clinic. You can also just Google ADHD medication guide, and this should be like the first or the second search result. So since we're talking about medicines in ADHD, I wanted to talk about something called GeneSight. So I'm sure you guys have heard of GeneSight or have had parents come to you with questions about a test to look at what medicines work for ADHD or not. Unfortunately, GeneSight does not offer the best review on ADHD medications, mainly because really the only some of the non-stimulants have genetic markers, but only methylphenidates have genetic markers. So it can't even give us any information on amphetamines. So for ADHD itself, it is not a good way to really get information about what those enzymes in that child body is doing in terms of metabolizing these ADHD medicines. GeneSight also does not tell us if a medicine will actually work. It does not tell us if the medicine will give the child side effects. GeneSight looks at specific enzymes in the body to help us understand if the child will metabolize that medication as expected, more slowly, more quickly, or a lot quickly, a lot slowly. So that's what the GeneSight testing really does. And I will say for me, it's a hit or a miss if it's useful or not. I tend to only recommend GeneSight testing if we are running around with our heads cut off and we're on the sixth or seventh trial of medicines and we really can't find a good fit for the child. I do not recommend it as like first line when I start a medicine because honestly, it can be wrong. It is not perfect. So I do not want it to influence any potential good findings just because a kiddo may metabolize the medicine slower than expected. Now, therapy options for ADHD, there's quite a few. So obviously, appropriate school accommodations should be on the top of your list. But there are therapies that parents can get involved with that can help manage, especially impulsive behaviors. That can be sought out through a therapy called parent-child interaction therapy or parental training and behavioral management. Both of those you can find therapists in your area by using psychologytoday.com. They have a giant find a therapist button. And so you can direct patients to go them themselves. Sometimes I pull up the website and I'll look with the family. It depends on the family. It also depends on time. And so that's one way. And the reason behind that therapy is to train parents how to appropriately respond to negative behaviors without like accidentally reinforcing them. So learning what to ignore and what to interfere with. This therapy though it's much better in the younger years, so like school age or younger, gets a little bit trickier, but that's where cognitive behavioral therapy can become more useful in the older kids, where they can learn to identify their impulsive thoughts and then be trained to teach their brain to stop and then think versus think and act all at once. OT is also another amazing therapy that can help children with ADHD. What OT can focus on is more on executive functioning skills. So those are things such as organization, how to sit in the classroom to focus, um, how to reward a kiddo, meaning let's do 20 minutes of focus and then 5 minutes of play. OT, private OT, can also help families with reward systems, setting something up at the home that can help reinforce better behaviors than the negative behaviors. And I think the trickiest part about ADHD overall is what to do when a medication is not working as expected. And so some of the first initial thoughts is did the parent give the child a good try at it? You know, I have parents who declare a medicine that is not effective after 2 days of trying it, and they just have to be educated on like that's okay. You know, sometimes when we start at the lowest dose, It's not to look to see if it's actually going to work. It's actually to look for side effects, those concerning side effects first. Because if we're going to have one of the severe side effects, we're going to see it regardless of the dose. And so if they're able to tolerate at a lower dose and we're just not having it be effective, the next step would be to increase it to see if it's just like we were just too low of a dose to see if it was going to really work. I also ask about if parents give the medicine correctly. Unfortunately, I have parents who will try to split long-acting formulations and then wonder why it's not working. So really understanding like, hey, when you open the capsule, do you put all the little sprinkles on one spoonful or are you separating it? And so if they end up separating it, that's a problem because then we don't know if the child really got all the dose that it needed. So it's always best to give all sprinkles in one spoonful. And then is the dose high enough? You can also always consider to try a different formulation within the same class. So the example that I gave there is like Ritalin long acting may not be working. Maybe we should try more. And Ritalin long acting has a biphasic kind of release. Maybe we should try Concerta, which has more of a continuous release. You can also try a different class of medicine. So, I give everything about 2 or 3 try in the same class before I try to switch to a different class. So if a trial of methylphenidate didn't work, maybe we should try amphetamine. You can always add a non-stimulant if they're currently on a stimulant to see if you get better effects. And then could there also be a co-occurring condition that is mimicking ADHD? Or is the co-occurring condition really the primary problem? And I see this a lot in females with anxiety and ADHD. They can really mimic each other because of the overlapping symptoms of inattention. So sometimes when I go through 3 or 4 trials of stimulants and it seems like the stimulant is making the anxiety worse, I will put us, I will say, let's put on hold the ADHD trials and let's try to treat the anxiety first. The reason why I typically choose ADHD is because stimulants you'll know within a week. With anxiety medicines, you typically need about 4 weeks to really see if it's making a difference. Um, so I always ask myself those questions. So those are my references. I definitely wanted to leave time, about 15 minutes, so I made it, for questions because I know this is a common topic and I'm sure you guys have some questions for me.
All right, thank you, Dr. Battistini. So some questions from the audience. For children that are diagnosed less than 10 years of age, what is the compliance rate for children as they get into middle school and high school? And for those that are not compliant, what is their feedback on why they don't want to take the medicine?
Ooh, that's a good question. So for older children, it's a good percentage of them, I would say after they hit 13, 14, decide not to take medicines. And what I hear from the patients is that they do not like how the stimulant makes them feel. And so what they feel or what has been described to me is some of them describe it as if it's a switch kind of giving their brain a whiplash from not attending to attending. Some also say it makes them feel more irritable. They don't like it changing their personality. And when things like that come up, I will typically, first of all, try to understand what they're feeling. But my second thought would be like, can we try something else or can we decrease the dose? Maybe we're too high of a dose now. Maybe you don't need as much stimulants anymore. Um, and the reason why I would try to keep them on the medicine is because what research has shown is that poorly controlled ADHD is what leads these kiddos into trouble. And trouble can be jail time, unfortunately. It can be substance abuse, just poor choices all around because their impulsivity is not well controlled. So, if they are having non-compliance issues, just taking that time to have that conversation and then offering them different options to try and making it clear that the goal is not to change who they are, that you really want them to be who they are, but the goal is to help them be more successful so they can learn and be a better version of themselves. Because ADHD can be quite disruptive in their lifespan.
All right. Next question. Can you have ADHD that is unmedicated and get all A's? I've had patients through the years who come to me in their late teens, early 20s with no records, say they have ADHD and did very well in school. This doctor is MedPeds. I'm
Yeah.
usually skeptical because you would think they would have had some impairment in educational performance.
Yeah, great question. So, and I will use medical students as an example for this one. So there are quite a few medical students who get a new diagnosis of ADHD when they start medical school. And the reason being, and this is what I would challenge you to think about, is that their IQ, because being higher professionals, we tend to have above average IQs. RQ probably compensated until it was challenged. And for many medical students, RQ is not challenged until we get hosed down with information in medical school. And so that's when the struggles of ADHD will start. I will also say that females are often misdiagnosed early on with anxiety when it was always ADHD. So I would also take that into account. So if a child is super, super smart, it is likely that their IQ compensated until it could not compensate anymore. But the diagnostic criteria remains the same. So they can't just be ADHD at work and not ADHD at home. So it's really getting feedback from multiple settings. And that may include like having their significant other fill out a feedback form about ADHD and then having a workplace coworker, if they're comfortable, or their boss filling out some forms about them, trying to get that secondary setting. I think it is possible, but I do recognize that social media may be overhyping the ADHD diagnosis. But again, it's about gathering the data to see if it's a true concern or not.
All right. Can you comment on drug holidays, weekends versus
Yeah,
summer?
yeah. So the official answer by the AEP is that they do not recommend drug holidays. Um, The reason being is because of this like whiplash kind of the brain is on, then it's off, then it's on and it's off, and it can be quite disruptive for a kid. Is it causing harm per se? Probably not. I will say my go-to kind of response is to let the families know the AEP doesn't recommend drug holidays, but I also recognize if the child's going to be outdoors playing all day in the sun, in the splash pad, they may not need it. And let them enjoy being a kid and run around and use that energy elsewhere. So it's a very family specific discussion.
Okay. Can you comment on current trends in research with magnesium with relation to ADHD? We get a lot of parents requesting magnesium levels and wanting to supplement with magnesium.
Yeah. So right now there's really no evidence to support magnesium in terms of ADHD. I've been getting more magnesium questions about sleep. This is what I've been doing. There's no evidence right now to even do magnesium levels. So at this point, I tell parents that there's no evidence to support such practice. But obviously these supplements are available over the counter. So I do educate the family at the end of the day. They're over the counter. It is your choice. I cannot recommend it. But I make them aware that over-the-counter supplements are not monitored by the FDA. So there is no way for us to be certain that what is being advertised is what is being received by the child. Um, so yeah.
Okay. And parents hesitant to place their young children on a stimulant using a non-stimulant like extended release Intensive. What do you suggest the parents report What do you suggest the parents report a paradoxical response like insomnia when taken at bedtime?
Are they asking like if you give a child guanfacine, which is Intuniv, and then instead of
Yeah.
being sleepy, they get hyper?
Yeah, what? Yes. That sounds like it. Yes.
Yeah, okay. Um, and so they want to know what to do or what does that mean?
Uh, Maybe what do you suggest the parents or well, I guess let's say the parents report a paradoxical response like insomnia when taken
Mhm.
at bedtime. What should you do?
Yeah, so it depends what you're using that guanfacine for. So if you're using the guanfacine to try to treat ADHD and you get more hyperactivity, I would say you may want to reevaluate what is the actual condition. Maybe it's not ADHD, maybe it's something else, and they don't need the guanfacine or clonidine. Now, if you're using it for sleep to help with sleep onset, in that way, you're trying to use a side effect that obviously is not happening. So I would just say it's just not a good fit for helping with sleep onset. But so that would be my response.
Okay. What therapeutic modalities do you recommend? I understand the guidelines to include medication plus behavioral interventions, but the modalities such as CBT, like they would use in adults, may not be evidence-based in the pediatric population for ADHD.
So there's more and more coming out that CBT might be helpful because we are recognizing that ADHD is usually not a standalone diagnosis and that there's usually probably a level of anxiety and depression also at play. So CBT is being recommended more and more that just because we're recognizing that ADHD is rarely standalone. Um, and then in terms of other options, occupational therapy would be another option because a lot of these kids really do need help with executive function skills to make like adaptive activities of daily living more helpful, more successful. So they can always refer to OT. And then in the referral to OT, you can put concern for ADHD, help with executive functioning, organization, attention to task. And that will typically clue in the therapist as to the sort of plan of care that child will need.
Okay. Can you repeat the medication guide website?
Yeah, here, I'll just pull up that slide again.
Okay. And then,
There, it's on the bottom of the slide.
perfect. And then, do you ever recommend L-theanine and L-tyrosine supplements?
No, it's my short answer. Just because we don't have the evidence base right now, but as a we can all recognize that social media has ran with supplements recently, and so I just really lean on the fact on what we truly have evidence for in terms of supplements. The only supplement that has been well studied in terms of ADHD, and the results are 50-50 on it, is omega-3s. So omega-3s, there are studies to show that when taken over a 4 to 6 month period consistently can help improve attention. Now, in terms of dosing and all that, that is manufacturer specific. Like I said, FDA does not control over-the-counter supplements, so the parents have to follow whatever the bottle says in terms of dosing. Um, but omega-3s tend to be, it looks like the studies, it's either effective or it's not effective, and the risk for side effects is very low. So that's the only supplement that I will discuss with families on a consistent basis.
Okay. And we put the link in the chat also for that for this table.
Okay.
And uh, how far out do you follow your patients with ADHD?
Yeah, so in the development center, because we have I'm the only full-time developmentalist right now. So in order to keep our wait list flowing, I cannot hang on to patients. So it's a matter of supply and demand right now. So once I am able to get a kiddo with ADHD on cruise control, which typically takes about 6 to 9 months, if they're just what I consider quote unquote straightforward ADHD. It takes me about 6 to 9 months to get them where they have to go, and then I tend to hand off back to primary care for continuation. And that's just because I'm the only one doing it, so I got to keep the revolving door going.
All right. All right. All right. Thanks. Great, great question and answer session. So thank you everyone for joining us today.